Hello, this is Dr. Laura Tigler. Welcome to my channel. This channel is meant to provide good general medical information. Please do see your primary care provider or your primary care doctor to obtain medical information that's tailored specifically for your needs. At the end of the medical information portion, I will be giving you some spiritual information. If you do not want to stay for that portion of the video, at the end of the medical information, I will let you know, and at that point you can click away. But first, please do like and subscribe. Today's topic is heart attack. This is a huge topic. I may have to do multiple videos, but we're going to do some basic information today. So many of you may have family members or yourself have had heart issues. When you have chest pain, you wonder, should I go to the emergency room? What should I do? The first piece of advice I would give you is that prevention is key. So please do have a relationship with your primary care provider or your doctor over a long period of time so that you can make better decisions if it comes to a point where there's a crisis. But generally, if you have chest pain, then you should present yourself to the emergency room. And then calling 911, let's say you're at home or in your office or elsewhere, if you have chest pain, that is a good first step to actually physically get to the emergency room. Because if you're having chest pain due to a heart-related issue, things can develop quickly and you might not be able to safely get to the emergency room unless you're in an ambulance. So that's the first thing, is make sure you have a relationship with a primary care provider who knows you. And the second thing is trust yourself. If you have severe chest pain, and we'll talk about symptoms more later, but if you have unusual symptoms or severe chest pain, then you should get to the emergency room in the safest way possible. And that might include calling 911 or an ambulance transportation. So nowadays we call heart attack acute coronary syndrome because we want to include in the word or phrase heart attack the three major different types of acute heart events that can occur. So rather than just saying heart attack, you can still use those two words for sure. We use acute coronary syndrome. If you want more information about ACS or acute coronary syndrome, you can do an online search. You can start with the journal Lancet and type in the year 2017. The title of the article that you might be interested in reading is Acute Myocardial Infarction. You can also type in your favorite search engine, AAFP, which is my professional society, American Academy of Family Physicians, the year 2024, Acute Coronary Syndrome Diagnosis and Initial Management. Or you can do your own search with a reputable website like WebMD or MayoClinic.com or FamilyDoctor.org. So acute coronary syndrome is defined as a sudden reduced blood flow to the myocardium, which is your heart muscle. On EKG, so you might be not in the hospital, you might be at your doctor's office or in urgent care. So the test that all doctors' offices have available is an EKG. That's a 60-second or 1 minute evaluation of the electricity that your heart is emitting. It's non-invasive, it's passive, and it can only give so much information, but it's a good basic first step. And it stands for electrocardiogram. Cardio is C-A-R-D-I-O, but historically we have named the EKG with a K, but it could also be termed ECG. They're both the same thing. So on the EKG, if the person's having symptoms, we might see ST elevation. So I'm not at the point with this YouTube channel where I am sharing the screen and showing you various pictures. I will get to that point, but I do encourage you to do a search and look for an EKG showing ST elevation. So it might be something that obvious. That person has chest pain, ST elevation. If they were in my office, then I would have I might have already called the ambulance, to be honest with you. But if I see the ST elevation, then for sure the ambulance does need to be on its way. The siren's going quickly within minutes. The patient needs to get to the emergency room. The EKG might be normal. There's no elevation of this particular segment that we label ST, Sam, Tom. And then if the person's having symptoms of what we think is a acute coronary syndrome, or you might call it heart attack, then we might already begin to label this as a non-ST segment elevation acute coronary syndrome. It's okay to clinically label it that way, or say possibly cardiac chest pain. Either one would be appropriate. And then another form of acute coronary syndrome, ACS, that is not found on the EKG is unstable angina or angina. So angina or angina is different than myocardial infarction, and you would use the word heart attack instead of myocardial infarction, but they're the same thing. Angina or angina is different from MI or heart attack in that the heart muscle has not been damaged, but the patient still had a sudden reduced flow of blood to the muscle of the heart, and it did create symptoms. So we call that ischemia. So ischemia means reduced blood flow. Let's talk a little bit about unstable angina. So when we use the word unstable, it has a clinical meaning. So we call it USA, unstable angina, if the symptoms are new. We call it unstable angina if the symptoms have been present previously, but they became worse. And we also call it unstable angina if the symptoms are at rest. The heart is not experiencing much demand, yet it doesn't have enough oxygen to feed the muscle, even when the muscle's not working very hard. That could fall under unstable angina under acute coronary syndrome. There could have been a sudden reduced flow of blood that caused that symptom. Symptoms of unstable angina include chest pain, pressure in the chest, tightness in the chest, squeezing in the chest, even a burning sensation in the chest, arm pain, shoulder pain, neck pain, and jaw pain. Typically these will be on the left, but not always. Shortness of breath. As most of the viewers know, I am a physician for almost 25 years. I have experience in the office and in the hospital. And yes, some patients do have heart attack, myocardial infarction, or angina with just shortness of breath, and they never have chest pain. That is possible. So shortness of breath, fatigue. It's also possible to have had a heart attack or be having a heart attack and only have the symptom of fatigue. Nausea, dizziness, indigestion, anxiety, and sweating. So the symptoms for angina could be intermittent, or they could be persistent. A good example of that would be fatigue. A patient could also have upper back pain. Now in my doctor mind, that I have to worry about other causes in the cardiovascular system for upper back pain, but that could be just a symptom of acute coronary syndrome, or like I said, from your guys' point of view, heart attack. Shortness of breath without chest pain, which we talked about. In men, these are the same symptoms, but they might also have worsening chest pain with cold temperatures or stress. Now, this can also happen with women. I had one woman, elderly woman, because I now treat elderly. For the first 21 years of my practice, I treated all ages, but now I am a senior specialist. And I had one elderly lady who had a heart attack, and what precipitated it was she was having an argument with her son. And I feel that the son should have known better, not to stress his mother out because of her underlying health conditions. And hopefully, if you're listening to this, you now know that Stress can precipitate a heart attack, even a change of temperature. That's why it just underscores why you do need to have a good relationship with your primary care provider, with your primary care doctor, someone who knows you. And I would say, being a senior specialist, I would like you to have a good relationship with the cardiologist, even if you haven't had a first event. If you have significant risk factors for acute coronary syndrome, I feel that you should see a cardiologist at least once a year. Okay, the symptoms might be relieved with nitroglycerin. So typically, if I have a patient with stable angina, and typically I'll be treating them along with my team member, a cardiologist, then I'll have them carry a nitroglycerin prescription in their pocket or purse in case they develop unstable angina symptoms or acute coronary syndrome symptoms. That buys them time to relieve the symptoms and call 911 and get to the emergency room. So angina, unstable angina, and myocardial infarction, whether it's ST segment elevation or not, is due from a ruptured plaque, a plaque or hardness that's on the arterial wall. And we've talked about that in prior videos. And so that, just like a poster on your wall in your bedroom, that can peel off, it can rupture, it can completely tear apart, but it can also just peel down or peel off. And platelets typically rush to that area to repair what they perceive as a cut. Let's say I fall down from bicycle riding and I cut my arm. I want those platelets to go to work and stop me from bleeding. And they do the same job, essentially, forming an aggregate clump and stop what they perceive as a rupture or a bleeding or an injury. In unstable angina, this clot or thrombus is not completely obstructive. It's non-occlusive. So blood can still flow somewhat. And therefore the heart muscle that's distal to that thrombus or clot isn't necessarily going to die. But in a myocardial infarction, the clot can be completely occlusive, which means obstructing the flow of the blood to that part of the muscle that's past that point. And at that point, that muscle dies due to lack of oxygen. Whether you think it's unstable angina or a full-blown myocardial infarction, in fact, there might be no way to differentiate that from the patient point of view. For all three of these conditions, you do need to go to the emergency room. So acute coronary syndrome, it could be due to an ST segment elevation heart attack or myocardial infarction. It could be due to a non-ST segment elevation heart attack or myocardial infarction, or it could be due to unstable angina. Those are the three categories underneath the umbrella of ACS, acute coronary syndrome. But all three of those categories, the patient needs to go to the emergency room. So risk factors for a heart attack or unstable angina or myocardial infarction are age greater than 65, being a smoker, and when you look at the literature, you'll see that sometimes when they do the various research studies, if the patient has quit within the past 3 months, we still put them in that category of a smoker. We have to cut it off somewhere. High blood pressure, hypertension, which I have done a few videos on. I encourage you to go look for those. Hyperlipidemia, so even high cholesterol level with no other risk factor for myocardial infarction can be a risk factor for heart attack. Body mass index greater than 25 in some literature or searches that you do, or body mass index greater than 30. But either way, whether you're overweight or obese, it's a risk for a heart attack. Family history. So prior to an event such as an ACS, acute coronary syndrome, the person might already have established with their doctor and their cardiologist, which is obviously my preference, if you have risk factors that I just named, And then they might have already had some imaging or tests, and typically one of the tests might be a stress test. And the stress test might not show any abnormality. That is possible, yet you still have plaque on your arteries. So please do keep that in mind. You could have a false negative, or it could be that the disease is progressing. Typically it takes about 20 years for significant plaque to develop on the arterial wall. So our tests before an event, such as an ACS, are not perfect. But having that relationship and as much information as you can will help overall treatment, evaluation, and treatment. So an EKG prior to having an ACS, you might see some nonspecific changes like ST depression. So instead of that particular segment of the EKG being elevated, it might be a little depressed or down. There might be minimal ST elevation. There might be T-wave inversion. That's another part of the EKG, is a wave that we just call it T. Instead of being up, it might be down. And there might be what we call a Q wave. So there's a part of the EKG where the line goes down instead of going up. Outpatient, there is no, you'll see some, when you search, you'll see some sites that will say outpatient. There is no validated clinical decision tool, but I'm going to talk a little bit about another clinical tool that does have some validation, even outpatient. So patients with ACS, acute coronary syndrome, receive coronary angiography with percutaneous coronary intervention. The percutaneous coronary intervention is abbreviated PCI. It's a minimally invasive test where we take a catheter and we put it in an artery, and then we go visualize your heart arteries. You might even have surgical revascularization. These are procedures that will be done after you present to the emergency room, have definite evidence that there's damage to your myocardium or heart muscle, and then we need to do an intervention to save your heart, basically. You might be put on dual antiplatelet therapy. Obviously, aspirin is an antiplatelet medicine, but we have other stronger antiplatelet medications that we might give to you as well. So dual means two. So you might be put on aspirin and another prescription antiplatelet medication. While you're in the hospital, we'll be giving you some medication to make sure that you don't have or develop any more clots. And we'll be doing that with IV access. If you've had an acute coronary syndrome, we do want you to be on a statin medication. You might already know that a statin medication was developed specifically to lower cholesterol, and now you know cholesterol is a separate risk factor for heart attack, so it's worthwhile to be on a statin medication if you have high cholesterol. But we do recommend that you take a statin medication if you've had a heart attack, even if your cholesterol is normal. So a statin medication has protective qualities that help prevent a subsequent myocardial infarction, and you'll want to be on that the rest of your life. Beta blocker, I talked about that in prior videos. A beta blocker is a prescription medication that reduces the stress on the heart, and so you want to be on that after you've had an acute coronary syndrome, and you'll want to be on that type of medication the rest of your life. SGLT is a relatively new medication, although it's been very well researched, and I have done a few videos on that, and that helps prevent heart problems as well, further heart problems. The SGLT, it stands for sodium glucose cotransporter 2 inhibitor therapy. We do want you to stop smoking, and we also want you to get a flu shot. So the flu shot has been very well studied, and it does help prevent the flu, but it also helps prevent a subsequent myocardial infarction. So you'll want to get a flu shot just to protect your heart. Isn't it interesting how some prescriptions or vaccines do the job they were intended for, but they also have other benefits? And the flu vaccine is an example of that. And then cardiac rehabilitation is basically physical therapy for your heart. So typically your cardiologist orders that, but it's not uncommon that I go ahead and order that for the patient. when they come see me after the hospital. In the emergency room, chest pain patients get worked up. In the end, about 2 to 4% of chest pain patients have the chest pain because they had an acute coronary syndrome. That might not sound like very much, and it might sound to you like, oh, I'll take my chances. I don't have to go to the emergency room. It's only a 2 to 4% chance that it's my heart. So these numbers I'm giving you, I just pulled them from a 1994 journal article. These numbers can change. 1994 was a long time ago. But I'm trying to give you an idea that if you have typical chest pain, it might end up being that it's not an acute coronary syndrome, or from your point of view, a heart attack. And in very small number of cases, it is from an acute coronary syndrome. But it's still very worthwhile to follow. We doctors go by evidence and science. So you can't go by feelings or whether or not your intuition says this or that. I mean, you can, but it can so often be wrong. So we want to have a method that is more reliably accurate. So that's why I'm giving you this advice, so that you go along the proper steps. Remember, you're going to first see your primary care provider, have a good relationship. If you have risk factors for cardiac disease, then you might already see a cardiologist. And then if you have the symptoms that I mentioned earlier, then you're going to present yourself to the emergency room. And then we'll, in the hospital, do the proper next steps as well. So I told you that 2 to 4% of the time the symptoms are from acute coronary syndrome. About 10% of the time the symptoms are from stable angina. So it ended up being that it wasn't a sudden reduced blood flow. It really was just a gradual reduced blood flow. So we call that stable angina. It can also be due to costochondritis. Costochondritis is an inflammation in the rib cage area. About 20 to 50% of the time, chest pain patients end up having costochondritis. And I can do another video on that, but basically that's not at all related to the cardiovascular system. 10 to 15% of the time, a patient might have true indigestion, because I mentioned that as a symptom above. But so GERD is gastroesophageal reflux disease, or you might call it heartburn or acid reflux. So about 10 to 15% of the time, it could just end up being that it was the gastrointestinal system, not the cardiovascular system. So sometimes it's an entirely different body system that caused the problem. And then about 7.5%, according to this particular article in the Journal of Family Practice from 1994, it's somatic discomfort. And that could be you were working out pretty hard the other day and you have maybe a muscle strain or that sort of thing. Okay, so, but other times it could be that the chest pain is from very serious conditions that also need presentation to the emergency room. And this could include pulmonary embolism, aortic dissection. Aortic dissection just means that huge artery that comes out of your heart, when we say dissected, we just mean there are several layers in the wall of the artery. And in this particular condition, the layers can rip apart. It's super painful, and it's just deadly when that happens. That main artery is what provides blood to your entire body. So if it has a sudden catastrophic loss to its function, then that's going to be sudden death unless it's immediately caught and treated. Esophageal rupture, not too common, but it can also be a cause of symptoms that seem like it's a heart attack. And then pneumothorax, tension pneumothorax, and that causes sudden pain in the chest wall, and that can also mimic an acute coronary syndrome. So in my organization, we do still sometimes type in typical chest pain or atypical chest pain, but for the most part, that nomenclature is gone, and we now describe chest pain as cardiac chest pain, possibly cardiac chest pain, and non-cardiac chest pain. obviously, sometimes we can't label things in those 3 different ways until after the workup has been completed, usually in the hospital. There is a guideline called Marburg Heart Score. Marburg is spelled Marburg, and we can use that in the hospital setting, and I'll show that to you in a moment. And then we'll perform tests, EKG I mentioned. Troponin is the name of a biomarker, a very good biomarker that tells us if the heart muscle has been damaged or not. There are other biomarkers, and sometimes we do draw those as well from the blood, but the troponin is the main one that we use. We might do some imaging studies like a CT scan of the chest or even an ultrasound. Sometimes in certain urgent cares or primary care offices like myself, we might have point of care ultrasounds, and we can do that. If the person has symptoms, we can do an ultrasound right on the chest and make sure there's no other life-threatening conditions like an aortic dissection, for example. And then stress testing. Remember, I talked about this before. A stress test is basically an EKG when the heart is under stress. So in the outpatient setting, you might do it when you're walking on a treadmill, because when you're walking, you're demanding more oxygen, so your heart has to work harder. It's stressed. It has to give you more oxygen to all those muscles. Or in the outpatient setting, we might do, and the inpatient setting, which means hospital, we might do a stress test by just giving you medication to stress your heart. But it's the same difference. We're trying to see if when we stress your heart, can we detect any weakness in the circulatory system around the heart. Because remember, there are arteries that feed the muscle of the heart, and those arteries can get clogged. And then coronary angiography is the gold standard test for the acute coronary syndrome patient. You might know it as catheterization, something like that, but that's the test that we use. And I wanted to show you the Marburg heart score, just so you know that we do everything by evidence. So that's why I was telling you, even if you suspect that you have some other cause for your chest pain, you do need to present yourself to the emergency room. Okay, so CP means chest pain. Sorry about that glare. If the EKG shows evidence that there could be some stress to your heart, let me turn off that light for you. I really have to have that light so you can see me, but okay, so there's chest pain, and that's what the CP at the top stands for, and then the EKG shows evidence that there could be a problem with your heart. That's why I put that arrow down to the heart. If it says yes, we can use the Marburg heart score. If your score is greater than or equal to 3, then you'll be going to the emergency room. If there's ST elevation, then you're going to get the coronary angiography. If there's no ST elevation, we'll watch your biomarkers. That's why I put TROP, and we'll repeat it again in 3 hours, etc. And then we'll still put you through the same algorithm if it ends up being positive. If it's no, there's no evidence of EKG findings, and you have a low Marburg heart score, less than or equal to 2, then you can be treated outpatient. That's the clinic. Okay, and then to further go down the Marburg heart score, so you can look this up online. If there's no ST segment elevation, but you have an elevated troponin, then we call that non-ST segment myocardial infarction, and that ANGIO, that's angiogram. That just basically means you're going to have a coronary angiography. And if there is no troponin elevation, we're still worried that you're at risk for a adverse cardiac event. So that's why I put low, intermediate, and high. And you can see it's 0 to 3 for low, 4 to 6 for intermediate, and high is 7 to 10. And then we'll proceed with the intermediate and the high risk patients. We might still do testing and the angiogram. Okay, so now you have the good basics on the acute coronary syndrome. I encourage you to research this yourself, and I will try to do subsequent videos with more help with technology and screen sharing, but also do more explaining on acute coronary syndrome, because there's a lot to the management after a person has had an event. This is the end of the medical information. I'm going to proceed with some spiritual information. If you do not want to stay for that portion, this is the point to click away. But first, please do like and subscribe. Okay, so my viewers know that I like to end my videos with spiritual information. I am a devout Christian. I'm not trying to proselytize or turn you into anything, but I have noticed with almost 25 years of medical practice that people or patients who have meaning in their lives bigger than just their personal story, like a faith or a spiritual practice or discipline or very close family ties, those patients seem to do better, and the scientific literature does seem to bear that out to some degree. So I usually end a video with a prayer, usually from one of my books. I do want to show you a couple of my books to encourage you to read. Doesn't have to be my books, right? But my first book is called You're Saved, and that's my name, Laura Tigler, MD. I'm also a military spouse. You can go to Amazon, type in You're Saved and Laura Tigler, MD, and then look for the roses, and you'll know you're in the right place. And this book is nonfiction, and it, I humbly submit that it's excellently written and you'll enjoy it. And then my second book, it basically tells my story of salvation and why it's important for you to be saved, and that a perspective you can have is that you really already are saved. You just have to realize it. Okay, this is my second book. It's a work of fiction. In my mind, it's just creativity. It does combine Christianity and Hinduism. And also, I humbly submit that it's excellently written, and it will be engaging. It's very easy to read on a vacation or maybe even at bedtime. Not for kids. It's got adult content. I am working on a third book. I don't have that available as of yet. And then I just wanted to show you a YouTube site that I really like. I have subscribed to it, and I have donated to it. And let me see here. There we go. So it's called BibleProject.com. And this is just their year in review for 2025. A year on the hillside. They did a lot of videos on the Sermon on the Mount. I really enjoy their videos. Oh my gosh, they're just so fantastic. And basically the BibleProject.com, it was started by two young people that they combined biblical knowledge with artistry and made some beautiful videos. And it's grown, and it's such a good, I feel like it's such a good place to, a charity you could give to if you want, but to learn from. I really encourage you to go and look at their videos. They believe that the Bible is one huge narrative explaining, how Jesus and God came into our lives to help us and save us and create us from the beginning all the way up to the end. That it's one big, huge story. It's not Old Testament for one religion, the New Testament for another religion. It's actually one huge story, basically about Jesus. So that's the Bible Project. I thought I would just give them a plug. I have no financial interest in them whatsoever. I just wanted to encourage you to do your spiritual practice. It's so important. Remember the interview I did previously where the doctor, Dr. Sheila Poole, had AIM, A-I-M, accountability, intention, and maintenance. So if you fall off the wagon, fall off the horse, just get right back on and do what you're supposed to do every day. I encourage you to exercise, eat right, and please do your spiritual practice every day. It could be prayer, meditation, reading, opening your mind, learning more, asking questions. You are important, and your questions really do matter. So that's the end of this video. I hope you enjoyed it, and I will see you next time.